Good evening, everyone, and welcome tonight to the Alex and Mo show. Since we have two Alexas on our show tonight, thank you guys for tuning in. Alex and I are honored to have Dr. Alex Hill, a young board-certified pelvic health therapist, joining us tonight. The first 3 weeks of July, our podcast will specifically be dedicated to men's and women's pelvic health. So tune in as we have two other medical professionals for the upcoming weeks of July joining us to share their expertise. So welcome, Dr. Hill, to our show tonight.
Thank you so much. I was so stoked when you reached out. You two are just total amazing PTs. I totally just fangirl over you. So thank you so much for having me on. I appreciate it.
Well, thank you. I didn't know that I was that popular, but I appreciate it.
Hey, take any fangirling you can.
Absolutely. I take it where I can get it.
Hey.
But thank you very much. Do appreciate you taking the time out to be with us tonight. I'm looking forward to our discussions tonight. Obviously, you got a lot of knowledge in an area that in the world of PT, I feel is probably just up and coming, although it's been around for a while. But it's just an area that hasn't been touched, so to speak. So I think you bring a wealth of knowledge to the PT world, to our show tonight, and hopefully our viewers can get some good info. For the students that may be watching, it's something that they can learn from you and follow in your footsteps. So a lot of good stuff this evening. But again, first and foremost, thank you for taking the time to be with us.
Yeah, absolutely. I'm really passionate about these two specialty areas, and when I have students DM me on social media, or if I'm doing a mentoring session, or if there's an established therapist that's interested in getting into these areas, I'm just like trying to reel them in any way that I can, and it's exciting to see the growth, like you said.
So Alex, you're pretty young, and I heard you talk at one of our Maryland chapter mentoring nights, and I was pretty impressed with your presentation. When did you first discover physical therapy?
So growing up, I was an athlete. I was the jock in my family. I have an older sister, and I had a lot of injuries, and so I was always kind of familiar with the athletic trainer and physical therapy, just with dealing with my own injuries. And I actually started out in college as pre-med in biochemistry. And so I graduated with a biochem degree. But the more that I shadowed with physicians, the more that I realized that wasn't quite what I wanted, what I needed, and kind of what my personality was. I wanted to have fun with people and build rapport and be able to really see them for a long time, and not just have it be this quick 10-minute in and out the door kind of thing that a lot of physicians have to deal with. And so I had a really bad hip injury when I was in high school, and that got misdiagnosed and kind of undiagnosed for about 3 years. I actually had one physician that told me, all the imaging is normal, all the tests are normal, like it's in your head, basically. And so to hear that from a medical professional when I was in near constant pain, at this point I was in college, I had trouble sleeping, sitting, walking to classes because of the pain, it was devastating. And, it took one medical provider to put their hands on me once I got to PT school, literally did a scour test, reproduced my pain exactly. Ended up being a labral tear. Had surgery, went to PT, and that was my really first full course of PT, especially after a surgery that I had. And just being able to see that difference at that time, I was, again, a biochem major. And so I was really pushing my rehab to go to Germany for a research event. And so I, working with my PT, setting the goals, seeing how much I could push myself, really got me into physical therapy. And so that's when I started shadowing more. I knew I wanted to get into PT.
As Alex mentioned earlier, lately I feel like pelvic health has become the sexy thing in PT. Before
Yes.
everybody wanted to go into to sports rehab, but especially new grads, even the male students, and everybody's like, "Oh, I want to do pelvic health." Or it was like, "I want to do women's health," and I was like, why? I mean, that
Right.
was definitely that
Takes
was
a special
definitely.
person to do it.
I know. Even with the lymphedema stuff, I hear therapists saying they want to become more lymphedema certified, and I'm like, man, it's tedious work, and the training is long. But to get a better background of you, you went to Kent State, and then you
Yep.
went to University of Florida. You did your residency at Duke.
Yep.
So give us a background and why specifically pelvic health? Was it because of your injury? And do you think your experience being misdiagnosed and being told as a patient that stuff is in your head? Because that could actually make someone go crazy when people keep telling them,
Yep.
"Oh, we think it's in your head," when you have like uncontrolled chronic pain.
Yeah.
How did that contribute to making you a better clinician?
Yeah, absolutely. Great questions. So I hadn't really heard of, physical therapy for pelvic health or women's health or for oncology. I had, family members and close family friends who had gone through cancer and battled cancer and had PT. But when I was in PT school, I had my first clinical rotation at a outpatient orthopedic clinic, and they had several pelvic health and oncology PTs there. And it's kind of funny. They were always laughing. I could always hear laughter from behind the doors. And so my clinical instructor was out. I know, right? So you wouldn't think that these two populations, you'd be laughing and having fun. But so my clinical instructor was out for a couple of days, and I was like, do you mind if I just shadow and see like what's going on? Like, what is this really all about? And as you mentioned, just with my own history of, basically being medical gaslighting, that people were telling me that there was nothing wrong when I was in pain, and working with these patients and seeing the profound impact that you could have within a single visit of one, validating what they were feeling and what they were going through, that it was a pelvic floor issue. It wasn't just have a glass of wine and painless sex is going to not be painful. Being able to see that and the profound impact that you could have within a single session, multiple sessions, it changed people's lives. And so I felt like when I saw that, I knew that was what I wanted to go into. I had a background in college. I started an organization, a chapter for Face AIDS, which was aimed at safe sex education and free HIV testing and doing a lot of campus events. So I was also comfortable talking about these kinds of things. And so I just, like I said, with my personality, what I had gone through myself, and just with kind of my skill set, and this was also the primary area in PT school that I kept wanting to learn more about. We had just had a couple-hour lecture, and that was it in terms of pelvic health and oncology, which that's a whole other topic with what our curriculum entails just in general on the PT level. But I knew that's what I wanted to go into, and I kept wanting to search more and more and more. I ended up having an 8-week clinical rotation in women's health, but we just had, some pregnancy postpartum population, a couple, true pelvic health patients. And so I knew that I wanted more. I knew that coming out of an 8-week rotation like that, it wasn't really truly setting me up to be entry level in these populations. And so that's what led me to then doing the residency at Duke to truly specialize in these areas.
So did you go straight from PT school to residency?
Yep. I moved there the week before I started my residency. I was waiting for my board exam results. So talk about stressful.
Wow.
Like moved in, like waiting to go. My mom was up there with me. She can tell you I was a nervous wreck.
So that's actually the same way that I did it. I finished PT school, did a sports residency, and in between moving to South Carolina and getting ready for that, like I still wasn't licensed. I was still waiting because I had taken the test right before I moved. Like the week that I was moving, I took the test, pack up, moved to South Carolina, and I'm just like, man, like I hope I pass, you know, like I need to be licensed, you know, and I had even sent one of the program directors. I'm like, just hypothetical, like
I did too.
if I don't get a license, like what happens here, you know, and thank God it never came to that, but yeah,
Right.
that was a very stressful situation.
Yeah.
So you go residency, and then from residency, what happens after that?
So after residency, I stayed at Duke for another 2 years. I was there for 3 years. I was involved with their breast cancer program as an IRB study, which was really, really cool. I was able to really dive into a lot of different research and speaking, and that's kind of what helped me get into those kinds of activities early on in my career. And I think that's one of the benefits of doing a residency. And especially if you're looking at ones that involve research and teaching and that kind of thing, is you get so much of that so early. I served on the board of directors for APTA Pelvic Health, then section on women's health, after a couple years of being in practice, and everyone else that I was serving with were established, well-known clinicians. So it was very much imposter syndrome, but also amazing to be in that situation. But I don't think without the residency, the amazing mentors that I had, the experiences that I was able to kind of jump into early, that I would have had those kinds of opportunities. So I went to Texas, was there for a year, missed the East Coast, and then moved to Maryland in Annapolis. I was there for a couple years, went through the pandemic there. That was interesting, for anybody that the last 3 years, I feel like it's just been a blur. And then just moved down to Florida last fall.
What brought you to Florida?
My parents. So I was telling Mo before we started, I grew up in Michigan, and, looking at colleges, I was like, oh, Florida's a little too far. Like, I'd love to go, be a Gator, but that's a little too far. And then, of course, after my freshman year, my parents moved to Florida.
Everybody comes here.
Right. So I think, with what a lot of people went through in the pandemic, not being close to family, not being able to see them, that kind of thing, and kind of reevaluating, okay, me and my fiance, where do we want to, settle down at? We love Maryland, but we wanted to be in Florida, close to my parents, get his mom down out of the cold in Minnesota. So it's been fun so far. Hot, very hot and humid now, but the winters are perfect here.
Gotcha. So where in Florida are you?
Jacksonville.
Okay.
Yep, Northeast.
So, go ahead,
Alex, it's interesting that you mentioned that you have a background in research, because I ran across a study today that said that Black women are disproportionately not considered for clinical trials after they've been diagnosed with breast cancer or any form of cancer. I know you try to help to bridge the gap in health disparity with your Instagram posts, which I love, by the way. So even though you're a fan of ours, I'm a fan of your Instagram page, because it's very informative. But I ran across that study today, and I was like, wow, patients are not even told about the availability of clinical trials that they could go through after being diagnosed with any form of cancer, and it's highest among Black and Hispanic women. So what do you think is contributing to that?
I think that's multifactorial. And I think you can also look at just general, social determinants of health, the disparities in cancer care. You look across all cancer types, and Black women are their death rate is higher than any other group consistently in the US, right? I think we need to make that distinction. And when you look at those disparities, and you look at the trickle down effect, or you go up, right? If you go upstream or downstream, part of that stems from the lack of inclusiveness and involvement in clinical trials and in research. And, there's a lot of reasons as to why that may be. You look at these larger hospital centers, the populations that are in those areas, transportation, right? Like if some of these clinical trials require you to come to repeated appointments or repeated testing, that kind of thing, but a lot of people are having to rely on transportation to get there. There's I think a lot of different things that can be at play. Elephant in the room, also just bias in healthcare, with providers, not wanting other, a diverse group of people in the study. Or, the study one was that 2017, 2015, and medical students still think that Black folks have a higher pain threshold and are prescribing pain medications at a lower dosage. If you have that bias coming into medicine, that's definitely going to impact the type of research that's being done.
I have an
Literacy,
interesting,
everything.
I have an interesting follow-up question because historically, Black women, brown women, Alex could probably share from his experience, being Hispanic. We don't tend to talk about, pelvic floor issues or challenges that we have. So as a clinician, how are you able to get that, past medical history and get them to be as descriptive in their subjective report?
That's a really good question, and I think it's interesting now that I've been down here for a little bit, almost a year, the differences in regions as well. I think just in general in the South, I'm having to, go a little bit slower with patients in terms of we may not get all that information the first visit. They may need to build that rapport a little bit more, or they've never said those words before. They've never talked about that before, and so to now talk about it with a stranger is completely outside their comfort zone. But I do find that I'm having that type of interaction more in Florida versus like when I was in Maryland, for example. And so I think that what I try to do is ask them and put it in their court, use motivational interviewing as well. See what their concerns are, what they're comfortable talking about, and how they talk about things. So if they describe voiding as TT, then I may use TT, right, until they get a little bit more comfortable talking about those things. And I think also just normalizing talking about it. A lot of people just don't talk about it, or they're told by their friend or their mother or grandmother that, these things are normal as you get older, normal after you have a baby, especially for women, it's just, what we have to deal with kind of thing, which is very much not true, obviously. And so I think, explaining, 1 in 3 women or people assigned at birth, female at birth, deal with some type of pelvic floor issue. You're actually not alone. This is very common. It's just that people aren't seeking help. 1 in 3. Yeah. It's just that people aren't talking about it, not seeking help. They're not realizing that they can do something about it. And then also, I think what's really helpful is I use pelvic models in the clinic. I have for binary male and female models. And so explaining the anatomy of it and why I'm asking these questions, I'm not asking about your bowel, bladder, and sexual function just for kicks. Like, this is going to help you get better. And this is why I'm asking these questions. Once they understand that a little bit more, they're a little bit more open to talking about it. But again, we may not get all that information the first visit, and that's okay. We work with them on what level they're at.
Okay, thanks for answering that. I know as like a general physical therapist, I felt challenged because a patient can get very comfortable with you and they would reveal certain things to you. And I felt at a loss that I couldn't help when they talked about incontinence, because there's a huge difference having an overactive bladder. And everybody keeps saying, just do Kegels. But
right.
I found out today that Kegels is not good for someone who has an overactive bladder.
Yep.
My parents used to joke with me, like, they know that every time we came home from something, and every house that I've bought, I specifically had to have a bathroom close to the front door and to the garage, because I knew as soon as I got home,
key in the door syndrome.
So
that is a major trigger for people. Literally, key in the door syndrome. As you get closer to the door, it's essentially think of your bladder just getting into a habit, right? Like, think about kids in the classroom. right? They're waiting for the clock to be 3 p.m. They're getting ready. As soon as it hits 3, boom, they're out. That's the same thing as your bladder. It just gets trained for these certain situations. Walking into the house. I have some people, it's as soon as they get to their desk at work, when they start washing their hands, if they're in the shower. I mean, there's a lot of different triggers for people, and we can work on all that. It's just retraining the bladder and the nervous system, and not necessarily through Kegels.
Yeah. So, people go Google that, or, they want to diagnose themselves, and they would start doing the Kegel exercises for an overactive bladder, which makes it worse. So, can you explain the difference between, like, when you have urgency to go to the bathroom and have an overactive bladder, like some common things that someone can do to help to ease that before they go to like a specific medical professional to help with that?
Yeah. And so I think first we need to address this access to care, right? A lot of people might tell their primary care doctor, the primary care will refer them to a urogynecologist. And for the majority of people, they'll still get referred to physical therapy. We're going to be able to work with them usually a lot quicker than a urogynecologist can in terms of how much they're booked out, and able to utilize these strategies by the time they get to urogy. And then if they're having more issues or they need medication or a secondary or tertiary line of intervention, then that can be good. But pelvic PT should always be, first line option. Before starting PT, though, to answer your question, it's like looking at your pattern of symptoms. So for you, right, it's getting into the house. If it's triggered by bladder irritants, so something like coffee or tea, for me, it's tea and kombucha in the morning. I know that's going to make me have to go because these things are acidic. They are caffeinated. They're carbonated. These are things that are naturally going to irritate the bladder and make that urgency worse. So, for example, for myself, before I go for a hike, I'm not going to have a whole bunch of tea and kombucha because I know it's going to have to make me keep going to the bathroom, right? I'll have water. I'm not going to cut back on my fluid intake, but I'm not going to drink those things that are going to have to make me go. Before bed, not maybe having a glass of wine every night right before bed, because that's going to make you have to get up at nighttime. So paying attention to what you're drinking, what your specific triggers are, and really, like we just talked about, instead of immediately going to the bathroom when you get that urge to go, doing what's called an urgency drill. So taking a deep diaphragmatic breath, potentially doing some Kegels. If you don't have any pain, then it can usually be okay to do just a couple little squeezes. And that breathing, the Kegels, and distracting yourself can actually help to get your brain and the nervous system off of the fact that the bladder's giving you all this attention saying, hey, I need to go to the bathroom now. So over time, we retrain that bladder saying, no, actually, you're not the boss. I always tell people it is brain over bladder. And once you recognize that, that's really helpful for a lot of people.
Okay.
So you obviously do women's health, pelvic health, but you also do oncology, physical therapy, which I think is a very unique skill set. I don't know how many therapists, necessarily practice in both specialties. What drew you to the oncology side of things?
So they kind of always were together when I first started shadowing with the pelvic PTs. They were both pelvic health and oncology. And so I had that exposure early on. I'd had family members and close family friends who had battled cancer and seen what physical therapy could do, learning more about it in PT school and then in the residency. So with women's health, it's interesting that the description of specialty practice, the DSP, so basically what all falls under women's health, includes oncology. So it includes prostate cancer and breast cancer and gynecological cancer. Lymphedema actually falls under it as well. So when we get board certified, we actually have that knowledge that we need to take that exam. And so for me, again, it was just, they were always together. And I loved working with these patients. And, I think a lot of people, healthcare providers included, see cancer survivors as maybe frail or that they need to be easy on them and not push them. But really, they are so resilient And I think that we are consistently underdosing them in terms of their exercise. There's more and more research coming out that cancer-related fatigue, side effects from chemotherapy, radiation therapy, neuropathy, pain, cording, lymphedema, all these things do better with exercise. But when you talk with most cancer survivors and you say, hey, like, what have you been doing for exercise? Oh, my oncologist told me just to, go for a walk. There's zero dosing with that, right? They're not getting the amount that they truly need. So educating people on, the ACSM guidelines for exercise for cancer survivors and helping them progressively reach that is so impactful. I was immediately drawn to it, and I could see that these folks and these cancer survivors really needed also kind of a champion for them. As PTs in any specialty, we are, I think, more and more acting as primary care providers, right? And we're fielding, okay, so you maybe need a referral to this person. We still need to go through their, physician to get those referrals. But, being able to really help them find the other providers they need. So I routinely refer back to dietitians, to an exercise physiologist after they finish with PT, to a sex therapist, to family medical therapy. I mean, there's so many other different specialties that we can also help refer them to. I think being able to have that type of role also drew me to this specialty.
I'm glad you mentioned that you guys collaborate with like dietitians, because from what I've seen, a lot of my patients who are going through chemo and radiation, they don't have an appetite. A lot of them complain that there's no taste, and they can't consume the nutrients that I would think would be good enough for exercises, because I still try to at least get like 1 to 2 sessions in a week with them when they're going through chemotherapy. But I'm realizing a lot more patients are getting like daily chemotherapy, which is daily radiation. Sorry.
Yeah.
And it does take a toll on them. So I also have to be empathetic and respect it if they don't feel like they're up to doing any exercises. But, I start off, at a zone where they're comfortable with, and then I try to progress as they start feeling stronger.
Yeah. Yep.
So,
And there may be some days where people come in and, we just do bed exercises that day. They're still moving. They're still being active. We might just need to, bring it back a little bit while they're going through that. But the biggest thing that I keep telling people is just, even if you're doing ankle pumps in bed, like, you gotta keep moving throughout treatment.
Okay. And go ahead, Alex.
Are you in private practice now?
No, I'm an outpatient. I'm a hospital-based system.
Okay. But do you do stuff on your own?
No, not right now.
Okay.
I'm focusing more on the education and that kind of thing, kind of digital media.
Okay.
Outside of clinical care. Outside of clinical care.
Is that something that is a goal for you, or do you have interest in doing something in the private practice where you're just kind of developing your own thing from the ground up?
I don't know. I think that's a very big question that I've grappled with over the years. When I first graduated, there was no way that I would have said yes in any universe. But the longer that I've been in practice and, talking with other people and seeing how private practice can be built, I've gotten a little bit more interested. I just don't know what that might look like, because, for me, it's a huge issue of access to care. And, I see these cash-based practices that are charging $200 for an initial eval. And you're thinking, how many people can do that, And as Mo said, for me, it's really important to have good access to excellent care for everybody. And so, I've seen some other people, Elise, the onco PT, there's a philanthro PT, Doc J. I've been trying to see how other people are doing it with sliding scales and that kind of thing, but it's still, trying to figure out how to get that good access to care while also not getting burnt out myself, right? So it's just trying to figure out what that might look like. Or, I really love teaching. That's why I started Oncopelvic PT, was to start giving this information, like, that people are nervous to talk about or don't want to talk about. And so that's how Oncopelvic PT started, but it's just, an unanswered question that I'm not sure about. There's a lot of things right now at my current institution. I'm at UF Health Jacksonville, and I'm helping to spearhead a transgender rehab program. We're building up our gynecological cancer program, our men's health program. So, there's a lot of things and benefits of being in a larger hospital system. We're a safety net hospital, so we're able to see literally anybody, which was really important to me when I was looking at jobs and moving down here. And that's one of the things that I love about this job and being in a hospital system and having, supportive upper management for these programs. It's, the impact that you have with that versus a single private practice. That's another thing that I kind of struggle with. And again, why I like doing these different courses in social media education, because you're able to reach so many people. So lots of questions in my head about that.
Speaking about digital creation, one of your last posts, because it's strange, when I saw you post it, a friend of mine was joking with me saying that, maybe we need to start investing in Depends, and
oh yeah.
you made you made the post that there are companies that are making lots of money telling people that it's okay to wear that and pee, instead of trying to fix the root cause of the problem. And you were giving some tips on it. So we would advise anyone who's listening, follow her on Instagram and Twitter at Uncle Pelvic PT. She has a wealth of information. And I do agree. We just like to slap band-aids on stuff and not take care of the issue. And a lot of us have in our minds that, because I've been doing research on like uterine fibroids, and some of the comments that I see, like some Black women make, that they think it's something spiritual, and I'm like, okay. So those, as a Black therapist, how do you help to debunk some of the myths that people have grown up with pretty much all their lives, and they still think hold some truth?
Yeah.
Because their parents told them so, their grandparents told them so.
Right. So I think coming at it in a non-judgmental way is very important. Even if in my head I'm like, oh my gosh, like what's happening right now? Outwardly, I would never say that. You want to validate what they've been taught, right? Where did that come from? Do you believe that? Why do you believe that? Because I think having an understanding of maybe why they developed something, whether it be fibroids or cancer or leakage or whatever, I think that can have a huge impact on somebody's, also their prognosis. And maybe an indication for, okay, maybe not necessarily spiritual, but if something else is going on, that I deserve to have this happen to me, or if they have a history of trauma, that may be an indication to also kind of tag team with mental health provider and work with them on that. But I think first and foremost is just kind of validating what they're thinking, and then going into kind of sliding into some of the more evidence-based information about, well, this is actually how things happen. This is the physiology behind it. There's two gals, Carla and Megan, with Physio Sage. I'm not sure if you've heard of them. They just did a patient educator summit, but they do a lot of really great content and education for PTs to become better patient educators. And so I followed a lot of their tips. And so I've changed how I educate people to really tailor even more than what I was doing before. I have a laminated piece of paper that I'll draw on, and we'll work through things together. And so we make it interactive. So it's not just me, a provider, telling them, no, you're wrong. It's let's kind of work through this together.
I have a question from someone. She is postpartum,
Mm-hmm.
former athlete, wanted to start resuming uh, working out, however, is having leakage when she's squatting and lifting.
Mm-hmm.
Is that common postpartum?
It is common, but there's, you can do something about it, which, I think that's the biggest thing is, people say it's common, not normal. Well, it's common is kind of normal after you just had a 9-month pregnancy. Your body went through a lot, right? But you don't have to deal with it. So depending how far out postpartum they are, if they were exercising during pregnancy, those are all things that can have an impact on their prognosis. If they had a vaginal delivery and they had tearing, depending on the severity of the tear, if that damaged any of the pelvic floor muscles. So there's a lot that can be at play with it. I found that besides just checking the pelvic floor, for these folks is looking outside the pelvis, right? The whole body is an entire kinetic chain. So if we're only looking at the pelvis, we're missing the entire rest of the body and things that could be at play. So I'll routinely watch, like, how are you squatting? Am I seeing, deviations or issues with your hips, in your back, with your breathing? Are you holding your breath at the bottom? When you're at the bottom of a squat, your pelvic floor essentially lengthens. And so if it's already lengthened and you're holding your breath, you're already putting yourself at a higher risk for having leakage. So a lot of times I'll work with people on just breathing mechanics, how to properly breathe. There's no best way to breathe, right? But what will work best for you, coordinating that with their movement. We may need to strengthen the core and glute muscles. There's a lot of different things that we can do to address it, but it's not necessarily just doing a whole bunch of Kegels or, Kegling at the squat. We need to figure out what's actually going on with it.
What about those who leak with coughing and sneezing?
Yep. So a relatively simple fix for that is something called the knack. So it would be where you Kegel as you cough. So you would breathe in, Kegel, cough, and then relax. And so that's typically what we'll instruct people to do, but only obviously after we do a pelvic exam, we make sure that there's nothing else that could be contributing to it. If they're having, constipation with that stool pressing onto the bladder can make it more likely for you to leak as well. So for a lot of people, we also work on their bowel issues to help with the bladder issues, which people don't. They're like, why are you asking about my poop? I'm like, well, they're really close together.
So Alex, we needed that for home health patients.
Yeah.
Exactly.
So you mentioned being, obviously you work in a hospital system, and you seems like you're spearheading a lot of different projects within the pelvic oncology. What relationship do you guys have with the OBs?
We have a really great relationship with the OBs, the urogynes. Something I really like about the system and what I've been, I think, very fortunate with all of the systems that I've been in, is that the physicians, the NPs, all the advanced providers really are collaborative. They want to do what's best for the patient. A lot of times I find that there's maybe room for an additional in-service for, best practice or updated practice guidelines, the 4th trimester pregnancy, getting people in postpartum at 6 weeks, sometimes before, not just, okay, you're 6 months out, you're still having painless sex, you're still having leakage. Okay, now let's send you to PT. Like, let's get them in sooner. So educating, I think, has been really helpful. In terms of what we can do as PTs, what our scope is. We just did an in-service with our gyn-onc team, our gynecological oncology team. And, we were talking about everything from oncology to, cancer-related fatigue, lymphedema, and that's lymphedema in the abdominal region, genital region, legs, dilator training if they've had radiation, pelvic floor training, and they didn't even know everything that we did. And so I think continuing to educate all these different specialties and providers on what we can do, when to refer, And also, that you can, like I mentioned before, you can refer to us before referring to a specialist. We have doctorate degrees. We know when it's appropriate to treat somebody versus when we need to refer them out. And I think, again, with them having a better understanding of what we can do and what our depth of knowledge is, especially in these specialty areas, has been really helpful.
Speaking about referring, do you guys ever refer to holistic practitioners such as like sexologists and stuff?
Yeah, so I'll in Jacksonville there's not many sex therapists. There's one in North Carolina that I will never forget because as a new grad I was like, what is a like what do you do? And she was just so gracious and kind of explaining everything, and she's got a great podcast that I'll refer patients to and that kind of thing. Acupuncturists, there's growing research, not level A excellent research, but there is growing research that acupuncture can be very helpful for different conditions. Myself, I have IBS, so I have my own gut issues that I've been working on. And, the biggest thing for me wasn't the medications. I use those as, if I'm having a flare up or something like that as needed. But the biggest thing for me was working with a dietitian and an acupuncturist and with counseling. And especially for BIPOC folks, it's important to talk about mental health and the role mental health has in our conditions, and especially pain conditions, these chronic conditions, in managing that better. And so, telling them my own story, and they're like, oh, well, if you've done counseling, okay, I guess I could maybe do counseling. It just takes one person for them to hear that they did something, to be able to have a little bit of courage to do it. But I love working with other practitioners. I think it's really helpful.
Okay, good to know. One other question, assuming it's from a male, talking about dripping after he uses the restroom for number one.
Yep. So that can either be a terminal dribble or a post-void dribble. So if you urinate, kind of shake, and then you're still having some dribble, that'd be a terminal dribble, meaning it's right at the end of urination, versus a post-void dribble. You go pee, you wash your hands, you start to walk away from the toilet or the urinal, and then you have the dripping, then that would be a post-void dribble. Both of those, there can be a lot of different reasons for why that may be happening. But sometimes it could be from an overactive pelvic floor, not allowing the urine to completely release from the urethra. So there's some urine left over in the urethra. Depending on the age, it could be from an enlarged prostate. There's a whole lot of things that could be at play, but that is something that I'll get referrals for in PT, and we'll ask about all those things. Do you have that issue if you sit to urinate versus if you stand? If that's the case, for me, that's saying that it's probably more likely a pelvic floor issue, because when you sit, your pelvic floor is able to relax much better than if you're standing, because they're stabilizing muscles, right? They're going to help support everything. So there's little things
I was gonna ask a very dumb question.
No, there are no dumb questions.
I feel like Channing Crowder at this moment. But are you saying that it's better to sit and pee, because a lot of women will probably be happy to hear you say that, so they don't miss the bowl and pee all over the place? But
for the majority of people assigned male at birth, standing is typically fine.
But to help with the dripping,
try sitting. That might help. If it does, then might be a pelvic floor issue. In that case, then you definitely want to go see a pelvic floor PT to address anything else that might be going on. Not uncommon, if there's urinary issues, for there to also be sexual issues, because those nerves and those functions are all very close together. So, I've worked with people who have leakage at climax, pain with, erectile function or orgasm. And it's not uncommon that you'll see both of those things together. So, yep. We ask all the questions.
Well, I noticed, like, with certain things, like, as I told you, I've been doing a lot of research on, like, uterine fibroids, like what encourages the growth and stuff like that. And alcohol was something that they mentioned does encourage your growth. So for men who are having these post-voiding dribble, as you put it, does alcohol consumption contribute to that as well?
It potentially can. I'm not sure of any specific research off the top of my head. If that contributes to, say, like an overactive bladder or something like that, then that potentially could. Usually with alcohol, we'll see that more of like with an overactive bladder or urgency, that kind of thing.
Okay. Good to know.
Have you had any experience working with like spinal cord injuries and the pelvic, impairments that can come along with that?
Yep.
And
yeah, go ahead.
Oh, I was gonna say, and what, obviously, because it's a little different when there's neurological involvement, as we all know.
Yep.
That's gonna kind of change the playing field a little bit. But what, if any, positive results have you been able to deal in that population?
Yeah, so I have experience working with the neurological populations. That includes spinal cord injury, Parkinson's, the whole gamut of things. A lot of times it comes down to the type of neurological insult, the severity of it, the chronicity of it. But also it will come down to just a lot of education and behavioral management. So, if they really don't have, if they have, for example, a neurogenic bladder, where it's flaccid, so it's not able to contract to get urine out. There's different maneuvers that we can teach them, timed voiding. We don't necessarily teach, the intermittent catheterization, but we can help make sure that they're getting the proper amount of fluid, that they have, that timed voiding or timed cathing schedule, avoiding bladder irritants, making sure that they're managing the constipation, caregiver, family member, friend education as well. So a lot of times the behavioral management is very helpful, even if the pelvic floor, even if we can't do a whole lot with the pelvic floor.
So you mentioned proper fluids. What is the right amount of fluid?
Great question. And as always in physical therapy, it depends. So, everyone thinks, I need to have at least 8 glasses of water. I need the 64 ounces. It really depends. Yesterday I was out doing a bunch of yard work. It's Florida. It was, I think, 80 degrees and 87% humidity. I obviously need a lot more water yesterday than today. And I was indoors treating patients. In general, so there's one recommendation of half of your body weight in fluid ounces. When you actually calculate that for yourself, it's actually a lot. I generally go on the couple rules of: one, your urine should look like the color of light lemonade. So if it's completely clear, you're maybe overdoing it. And if it's a really dark yellow, you ain't getting enough. So to up that water, right? If some people want a hard, fast rule, then I'll start with, half of your body weight in ounces and just see how you feel. Like if you feel waterlogged, don't drink that much, right? But if you're only drinking when you start to feel thirsty, that your body's already triggering that you're starting to get dehydrated. So we don't want to ever get to that point. So, it's helpful to just kind of sip throughout the day versus try to chug a bunch of water, because research shows if you chug a bunch all at once, oh man, I didn't drink my water today. Let me just get in a glass right before bed. That's going to make you have to get up at nighttime, right? Just drink all that water. But when you drink a lot of water quickly, it actually triggers the kidneys to produce more urine quicker than if you're just kind of sipping it throughout the day. Other considerations would be, what are you eating? If you're having a ton of fruit, right, or a ton of vegetables, it has a lot of water content in it that people don't really think about. So that's another consideration for people to have as well, is are you also getting that water and other food in your diet as well? So it really depends.
And then a follow-up question to that is, what's a good cutoff time before bed to take in fluids?
It depends, of course. In general, you want to avoid at least an hour before. If you're already getting up a bunch at nighttime, some people, I have them cut it off like 2 to 3 hours before and just do little sips. But for the majority of people, at least an hour before, as long as you're not chugging water, you should be good.
Well, Alex and I are both in home health, and I know I have clients who said, when I ask, okay, how much water did you drink today? Like, if I'm there like about 2 o'clock for the visit, and they would be like, meh, they was point to the bottle and it would be like 3/4 full. But then they were like, oh, I had coffee, I had 2 Diet Coke, or I took a sip of cranberry to help me pee.
Yeah.
And I'm like, that doesn't count. But they're like, it's liquid.
Right.
So,
but they're all bladder irritants. And they're diuretics, right?
Can you explain that it's not the same?
Right. So you do so I can't remember what the exact ratio. I've seen different ones that are recommended, but out of your total fluid intake during the day, 2/3 of it should be water, for example. So if you're having any kind of pop, any diet pop, I mean that the artificial sweetener and that alone is going to trigger you. I've had some people just simply switch from a diet pop to a regular pop if they really just do not want to give up like the Coke, for example, and just literally switching to regular helped their symptoms because of that artificial sweetener, right? So in general, the other fluids are fine to have, but if they're all irritants and that's not helping you, you're just you have to go more, for people that don't like drinking water, I'll recommend different things like, infusing it with like mint or cucumber or something like that. Or there's like Noon tablets that I'll recommend people to get. It doesn't have anything artificial and it doesn't have any sugar. So for anyone diabetic, they don't need to worry about that. Or like herbal tea, or if you want juice, like cut it with some water, or, there's different things that you can still do to enjoy drinking things, but not to the point where it's having you to have all these symptoms and you're not getting the fluid that you need.
Okay.
So a couple of questions. When you say a bladder irritant, what exactly does that mean? Does it cause the bladder to contract more?
Yep.
Okay.
Yep. So basically causes it to contract harder and faster.
Now, what effect, if anything, does that have with the kidneys as far as producing more urine? Like, do they go hand in hand?
Typically, but it's more so impacting the bladder lining. So, and you'll see this even more so for women who are menopausal or postmenopausal, because they've lost that estrogen in the body, and that actually makes the lining of the bladder more irritable, I guess. If you then have these bladder irritants that didn't really bother you before, but now they do, it's because it's just so much more irritable with drinking these things.
Gotcha. All right. Now moving on to another serious topic. I mean, obviously here recently we had the Supreme Court overturned, Roe versus Wade. You mentioned earlier, obviously you're a pelvic health specialist. You said you served on the board of directors at one point. There was discussion in PT Twitter about, whether the APTA would make a statement, when they would make a statement,
right?
And all those things. And there was discussion among, therapists that said, why should they? Why should they make a statement? Why do they need to make a statement? I'd like to hear from you as a pelvic health specialist and a former board member. What this means to you in your practice, and B, as somebody who is basically in the trenches, deals with these patients, has access to these patients, like what effect and how this could change how you do your job moving forward.
Yeah, I think that's a great question. And I'll preface by saying this is my personal opinion. This doesn't have reflect anything on employers or anything else like that. This is my own personal opinion. I think that, this is the right to choose. This is healthcare. And I applaud the APTA Pelvic Health. I believe the Pediatric Academy may also put out a statement, and APTA for putting out statements that this is healthcare. This, will impact us. I've seen some things that are kind of going around social media where people are telling people to not tell their medical providers that they're pregnant, because if something happens, then that would be one additional person that could be liable for them getting in trouble, to say the least, which has a huge impact on our care. For me, in pelvic health, in general practice, we don't perform internal exams during the first and second trimester. If I don't know that somebody's pregnant because they don't feel comfortable sharing with their other providers that they're pregnant, that could increase some liability issues. It could increase some safety concerns. And I think about, some of my cancer survivors and them finding out that they're pregnant and having to choose between having a pregnancy or getting chemotherapy, or having to delay their cancer care. And not having that ability to choose is going to definitely impact how I would treat them, both on the pelvic health, women's health, OB side, and on the cancer side. So when people say that this isn't a PT issue, I personally disagree with that, and the impact that it will have on our patients and how we treat them.
Well, you both live in a very interesting state. Live and work in a very interesting state.
Yes,
I would definitely
have
to say.
Yep. Yep.
Wow.
Looking forward to voting this fall.
It'll be good. It'll be good.
Yeah, it's.
I think as a whole, as we've seen over the course of the last couple elections in this country, our country is pretty evenly split, and because of that, anything could happen.
Right.
Anything can happen, and a lot of times what you think is going to happen is actually what doesn't happen, and yet something else. And everybody has their views, everybody has their ways, and what they feel is right, wrong, and better for them, and whatever, it's always something that just kind of is what it is. But anyway, I do thank you for your opinion on the matter, because again, it's very important that, as with anything else, we always listen to the people that are experiencing, right? Like, we always like to talk about how other people should feel, how other people should act, but we've never spent a minute a day in that person's shoes, whether we're talking about, healthcare, access to healthcare, or as clinicians, and what these clinicians have to go through, and clinicians like yourself, how this affects your practice. Like, if it doesn't even add up, but as an example, if something came across where orthopedic sports PTs now have to change the way that they practice because of a law that's been passed, I wouldn't expect a pediatric therapist or somebody like yourself who doesn't necessarily deal with them on a day-to-day basis to really say how that person should feel, how they should treat her, whatever the case may be. So I do thank you for your opinion on the matter, because we need to hear from people like yourself. We need to know what it is that's going on, what you see with your patients, what your patients feel comfortable telling you, and how that impacts, everything moving forward. So with that, thank you very much for spending time with us. It was awesome. I learned a ton.
So did I.
My pleasure.
So did I.
Very good questions.
This is information that needs to get out. This is information that needs to get out. People are embarrassed, scared, whatever it is, and there's help out there. They don't have to be alone. They don't have to go through this alone. There's people and partners that can get help and improve their quality of life. So a lot of knowledge that you shared. You're doing awesome with the Oncopelvic PT. So kudos to you. Keep that up.
Thank you.
Alex, I told her Was it last year I told you this, that I think you're gonna be the youngest president of the? I told her that. So
I mean,
remember that
honestly,
I
like
told her that.
without getting too into it, like I think that I don't know how old you are. I'm not gonna ask you how old you are, but I'm pretty sure you're younger than me.
33.
Okay, see, I think you're a shining star. I legit, honestly feel that
See?
way. I
See, I
think
told
that
you.
what you've done in a short amount of time uh, could go a long way in our profession and specifically in your specialty area. So keep it up because, like I said,
you.
it's a new area that's untapped, and it's now, as Mo mentioned earlier, the sexy thing to do it.
Yeah.
And I think that you're on it. I think you're doing it the right way and doing it for the right reasons, which is to help the patients. And
Right.
I've always felt that as long as you do that and you put the patient first and all that stuff, all the other rewards and the good things that we want are going to come. You know,
Yeah.
whether that down the road means you open up your own practice or you just grow a program that now becomes, you know, world renowned because of something that you've done, you know, in Jacksonville. Even though you went to that school not too far from there that we're not going to get into, you know,
Says the guy drinking from the Cowboys Cup.
it's
I know, I
still,
saw that.
it's still awesome to see what you're doing. If anything that Mo and I can help you down the road, please don't hesitate to ask us. We will always be here to help you however we can. So thank you very much for spending time with us. And as usual, to our followers, thank you for watching, tuning in. This is your first time watching, subscribe, follow us, like us, comment, all that fun stuff so that we can continue to put out the great content. Mo?
Yes, and don't forget to follow Dr. Hill at Uncle Pelvic PT. She's on Instagram and Twitter. She has a wealth of informative knowledge for you. She also has a link tree where she recommends products if you're going through chemotherapy, radiation, lymphedema. What else do you
Yeah, really anything
offer?
pelvic health, oncology, home exercise stuff. You know, what do you do after PT? What can you use? Water bottles to sip from, not chug, right?
Yeah. So please follow her. You would not be disappointed. So thank you again, Alex, and goodbye from the Alex and Mo show tonight.
Thank you so much. I
you.
really appreciate it.
No, it was a pleasure. Everybody have a good night.
Good night.